Guys, it's Nurse 20. There are lots of things that nurses are really good at, but one thing we're not so good at is reading an EKG. So here's a quick 5-minute lowdown on how to read an EKG. Now, we have to start by knowing what leads are where on the paper. So if you look above, I have an EKG, and it shows you leads 1, 2, and 3. Then we have lead AVR, AVL, and AVF, and that stands for augmented vector, right, left, and their foot. And then we have leads V1, 2, 3, 4, 5, and 6. And then you got to know where we place those electrodes on the patient's chest. And so here's a kind of a guide showing you where those electrodes go and how we get leads 1, 2, and 3. Those are used by combining some of those, the limb leads that we put on our patient to form those views. And if you want to think about the different electrodes that we're putting on the patient, is almost like a camera looking at the heart from that direction. Okay, so if we're positioned at AVR, we're looking at the right kind of upper side of the heart when we're looking at it. So look over that, push on the screen to pause it so you can look and see where all of those leads belong. Next up, you got to understand the coronary vasculature and where each vessel is located. So these break out of the aorta just past where the left ventricle is pushing the blood out into the aortic arch. We break off to feed the coronary arteries. Now we have the RCA, which is the right coronary artery, and that's going to feed your SA node and your right ventricle. And then on the other side, we have the LCA, or the left coronary artery. A lot of times we just call it the left main. And then that breaks into two main branches, our left anterior descending, anterior meaning coming down the front of the heart. And then we also have our left circumflex, meaning circumference. It kind of comes around the side of our heart. Now, it also branches off into little bitty diagonals, but those are the main vessels of the heart. So now that we understand all of those bits and pieces, we can look at an EKG, we can look and see where we have ST segment elevation, and then safely guess what part of the heart is affected. And if you look at this EKG here, I labeled it on what leads equate to which part of the heart. And I like to use the mnemonic I see all leads, so ISAL, to help me remember which leads indicate which part of the heart. But you don't have to memorize this, because if you just understand what part of the heart you're looking at based on what leads you're in, you can guess what part of the heart is being affected by this infarction or this starvation of oxygen to that part of the myocardium. Now, there's a few things that, there's reasons we need to know this, because we know that, let's say the patient is having an inferior MI, we know that that RCA is the affected vessel, and that's what feeds our patient's SA node. So that's why these patients having an inferior MI are going to be bradycardic, because if that SA node is starved, then that's not going to be generating the beat for the heart. It's going to be generated elsewhere in the heart. So that's why those patients are bradycardic. We also know that those patients are very preload dependent. So we've got to be very gentle with our nitro and consider giving an early fluid bolus because they're struggling with that preload. So that doesn't cover everything there is to cover when it comes to an EKG. It's there's much more to it. Like if we're talking about modified Scarbosa or looking at the South African flag sign, there's a lot more to it. This is the very basics of how to read an EKG, and I hope that helps you out. So my medic friends, help your nurse friends out. We're not very good at this. This is easy peasy lemon squeezy for you guys. So share this with any of your nursing friends who maybe don't know how to read an EKG.